As we all know, polycythemia vera is a chronic hematologic malignancies where, among other things, there's an increased production of red cells, which puts patients at risk for thrombosis. And the standard treatment for polycythemia vera is therapeutic phlebotomies, plus minus cytoreductive therapy, depending on patients' risk categories. And so as a result, most patients spend some time with hematocrit that is above the goal of 45% because they're seen periodically. And when they're seen and their hematocrit is above 45%, they get a therapeutic phlebotomy. Management of patients with PV can be a challenge because they're often iron deficient in diagnosis, and repeated phlebotomies can make iron deficiency worse. However, iron repletion is not usually recommended in PV patients as can make erythrocytosis worse. So managing this condition can be a challenge. So this is a trial of hepcidin mimetic in patients with polycythemia vera who are heavily phlebotomy dependent. In this case, it was defined as needing 3 or more phlebotomies in the 6 months prior to initiation of this therapy. And the way hepcidin mimetic PTG-300 works is that typically in polycythemia vera patient, hepcidin level is low. And as a result, iron is easily available for erythropoiesis. So uncontrolled erythropoiesis is happening in the bone marrow, and iron is available for that to take place. In the presence of PTG-300, which is a hepcidin mimetic, iron is restricted for availability for erythropoiesis. And as a result, it controls the amount of erythropoiesis that takes place in the bone marrow. And as a result, hematocrit comes down. And we're able to titrate the dose of PTG-300 in each individual patient to control their hematocrit and keep it at the right level where we want it without patients becoming too anemic. And so this is a phase 2 study, which consisted of 3 parts. First part is dose titration. So each patient starts on a low dose. It's a subcutaneous injection that's self-administered on a weekly basis. And every month the dose was titrated up to get hematocrit to be at about 45% or below for each individual patient. And then patients were maintained on this dose. And then the second part is randomized withdrawal. So patients are randomized to either get a placebo or to continue on the same dose that was effective for them in part 1. If a patient during this phase requires a phlebotomy, then they will stop the randomized withdrawal phase and will enter the extension phase and will go back on their last effective dose of PTG-300. And so the primary endpoint of the study is to see the need for phlebotomies during this phase, during the second phase of the study where patients enter the randomized withdrawal period. So what was presented at Icahn is preliminary results. And what it shows is that as soon as patients start treatment with this drug, the need for phlebotomy is dramatically reduced. We show a graph where, as opposed to the number of phlebotomies that patients require prior to initiation of the study drug, when they initiate the study drug, the number of phlebotomies is significantly less. And in each individual patient, they may just need a higher dose. And so they may need a phlebotomy until they reach their appropriate dose for that. This is a very exciting result as we're basically eliminating the need for phlebotomies in these patients. What we also look at here is their iron stores. And what we show is that even though most patients are iron deficient at start of therapy, as demonstrated by their ferritin level, when they start on therapy, ferritin level normalizes. We look at symptoms that these patients report. Patients with PV can be fairly symptomatic. And so we look at their symptom scores at baseline and during the treatment with PTG-300. And these are preliminary results because the number of patients that we have this data available for is still relatively small, but what we're showing is there is improvement in their symptom score, specifically looking at fatigue, in concentration, and in pruritus. And so these are some of the most significant complaints that patients with PV have. What we also report is that the drug is well tolerated and is safe. The most significant adverse events or the most frequent adverse events were injection site reactions that was seen in about 28% of injections. It was transient and none of the patients had to come off the drug because of the reaction. So most patients, as they continued on their treatment, the injection site reactions resolved. There were no grade 4 serious adverse events. And so this drug is effective in eliminating phlebotomies in patients that are phlebotomy dependent. And this effect was seen in patients that are treatment naive, meaning that the only treatment they're getting is phlebotomies, as well as in patients that are also receiving cytoreductive therapy, whether it's hydroxyurea, interferon, or ruxolitinib. So this effect was seen in all patient groups. So we think this is an exciting new drug that is potentially something that can have an effect for patients with polycythemia vera.